I'm Dr. Siddhartha Angadi. By training, I'm a cardiovascular physiologist, but for like the last 15 years, a large amount of my work has focused on looking at drug, exercise, diet interactions in cardiology, cardio-oncology populations, and then now in the last 4 or 5 years, GLP-1s.
And Dr. Kahan?
And hi, everyone. I'm Scott Kahan. I've worn a lot of hats in my career, but I think the most relevant for this, for one, I'm a clinician. I'm an obesity medicine doctor. I see a lot of patients and run a large practice focused on obesity treatment. And my background is training in public health, preventive medicine, and obesity medicine. So I think I can often bridge the clinical individual with the population level. And so hopefully we'll talk about some of those things.
Yeah, great. Okay, so I'm going to start with Scott first. So Scott, you've worked with the White House advising Congress, CMS, Center for Medicare, and you have a really depth of knowledge of obesity and chronic illness, and you have a degree in prevention and preventive health. Why don't you talk a little bit about how, I think most people don't know that GLP-1s are not new. And that's something we get all the time because people think GLP-1s are new. And about the confidence you have in the safety of the drugs.
Yeah, so there's a lot there. First of all, the first GLP-1, people think about Ozempic in 2021 when it got really popular. The first GLP-1 approved by the FDA was in 2005. That was exenatide. There were a number approved thereafter over the next few years. All of them lead to a little bit of weight loss at least. But it wasn't until the more modern GLP-1s that we started to see the kind of weight loss that we're used to today. By the mid-2010s, we had Ozempic approved for diabetes, for one, and then we had the first GLP-1 that was approved for weight loss. That was Saxenda, so liraglutide, which had initially been approved for diabetes, and then was named Saxenda for obesity. Over the course of that time, there's mounting data on improvements in a number of weight-related comorbidities. So we started to see the potential for GLP-1s to improve health in people that have chronic kidney disease. We started to see the possibility for GLP-1s to improve cardiovascular outcomes and potentially cardiovascular mortality. That was through the mid-2010s. By 2020, Ozempic was first approved, the diabetes version, Ozempic, was first approved explicitly to prevent cardiovascular outcomes in people that had cardiovascular disease. And then we had data as well on Saxenda to improve cardiovascular outcomes. So going into 2021, again, everybody thinks that GLP-1 started in 2021, but we have long data until then. On top of that, and this is something that people aren't aware of in my experience, the FDA has an incredibly high bar for approval of obesity medications and diabetes medications as well. This only started to some extent in 1998 and then in 2007. The FDA revamped their requirements for industry for approval of medications for obesity and diabetes. So, yes, there has been medications in the past that turned out to be not so healthy for people to take for obesity, to a lesser extent for diabetes. Today, though, it's highly unlikely that we would see that sort of situation, given that the FDA, has a very high bar for approval. So then, come to 2021, and since then, the data, both on safety and efficacy, just continues to mount. So we had Wegovy, which is the weight version of Ozempic, approved in 2021. In 2024, it was approved explicitly to prevent heart attacks and strokes in people that have obesity. In 2025, it was approved to prevent negative liver outcomes in people that have obesity. In 2022, tirzepatide, which is now approved under the brand name Zepbound for obesity, they published data on that medication showing more than 20% weight loss in the trial. And in people that did intensive behavioral counseling around that, they had closer to 25% weight loss. That is absolutely unheard of. We've had good medications for weight loss for about 25 years, but nothing like that. That is just about in the range of bariatric surgery level weight loss. That's more weight loss than you get with gastric banding, if you're familiar with that, and it's getting close to what we see with gastric bypass surgery. So we just keep seeing more and more positive data on the benefits and safety of GLP-1s, and I anticipate that will continue.
Great. I know I always think when Scott and I started working, we met the American Board of Obesity Medicine, and we were question writers for like 20 years or so. And there were no GLP-1 questions. Like, we were using other drugs and trying to make them fit the equation that we needed to solve, right? And now we have GLP-1s, and the questions are going to be totally different. Like, our questions are obsolete, that we wrote. Okay, so Sid and I met at the Grains Food Foundation, where we were both on the board advising, and he comes with a totally different experience than I do as a clinician. So I want to ask you, Sid, your job, and he's at UVA, University of Virginia, it intersects between diet, exercise, cardiovascular, metabolism, and drugs. And if you were trying to talk to an employer and telling them in the real world what your studies show, the benefits of GLP-1s, and maybe the benefits of stopping, or the lack of benefits of stopping and starting the GLP-1s in your trials.
Yeah, sure. So a couple of things to keep in mind, obviously, that the GLP-1s have a phenomenal track record right now in terms of reducing things like MACE, so that's major adverse cardiovascular events. Tirzepatide, in fact, in one of the studies even showed a reduction in all-cause mortality, reduction of about 20%. You also have tremendous benefits when it comes to things like pain from knee osteoarthritis. So if you look at the reduction in pain in these patients, it's almost equivalent to getting a total knee replacement, which is, striking. And of course, you got to think about the cost of a total knee replacement, which is considerable from an orthopedic standpoint. You have improvements in obstructive sleep apnea. So the apnea-hypopnea index goes down about 50-60%, depending on which drug you're looking at. So these are enormous benefits that you can expect when patients go on these drugs. Now, the one thing I will caution you, obviously, is that when you think about these meds, they're probably for life. And the reason why I say that is we have extremely good data showing that when people come off these meds, the weight comes back. And that's because body weight is extremely tightly biologically regulated. And one of the things you have to sort of keep in mind is that when you lose weight, you tend to lose it as fat mass and fat-free mass. Fat-free mass is the compartment that has muscle. And if you look at GLP-1s, about 25 to 40% of that comes from the fat-free mass compartment. But if you look at weight regain studies, and in fact, we're going to be presenting data on weight regain, not from GLP-1s, because that data doesn't exist right now, but we looked at caloric restriction studies, and we'll present that in Switzerland in about 3 weeks, so you're getting this hot off the press. When you look at weight regain, it's only fat. So if you're going to go on these, you're probably going to have to stay on them for the long term, which is, no different than thinking about statins for high cholesterol or, antihypertensive medications. But obesity is a chronic condition that is written into your genetic code. These drugs are not going to rewrite your genes, so you're probably going to have to be on them long term.
Let me jump on this for a second too, because that data on osteoarthritis improvement is almost unlike anything I've seen in my career in medicine, even considering all the positives we had in terms of cardiovascular outcomes and such. But it also, I think, gets to some of the risk-benefit data. So look, there's risks with GLP-1s, just like with any medication. But taken in the context of the potential other risks that we can get rid of, I think is interesting. So if you see that degree of osteoarthritis improvement, on the one hand, those are a whole lot of people that are not on NSAID medications for their osteoarthritis, with all the potential risks associated with that and the potential costs associated with that. That is potentially a number of people that don't have to get knee replacements, or at least may be able to push it out years to decades, potentially, with the costs and the risks associated with that. So, I think that we're getting close. I'm going a little bit off the topic here. We're getting close. We're not there, but we're getting close to seeing the potential for real hard outcomes on cost effectiveness and cost savings with using these medications. But that's with fairly narrow studies that just look at the actual costs of the medication and then maybe hospitalizations and such. When you broaden that out to consider the potential for savings of other medications, to consider the potential for improved quality of life without being in constant pain in your knees, with having better mobility and so forth, let alone things like employee satisfaction, patient satisfaction, I think we're very close to being able to make an extremely good cost case for these medications.
Oh yeah, and the one thing I'll add is if your knees hurt less, you might be more active, which is good. And just so you all know, we published a big study last year, 454,000 people from 6 countries. If you're more active versus less active, the reduction in mortality is 50%.
Yeah, and I think, I remember this fact from a while ago, but I think in Colorado they have a large study of the weight maintainers, people who've lost weight and successfully kept it off for more than 2 years, and the one common factor that everybody has is they walk 30 minutes a day.
At least.
At least, yeah. That's their one common denominator. Okay, so we're going to talk a little bit about adherence to the drug, right? Because that is our secret sauce, and that is the hardest thing in medicine. So, Sid, we know adherence is a big challenge with any medication, and what does the research tell you about adherence to the GLP-1s? And if people, some people say I could be on it for 2 months, go off of it, take it for a wedding, then if I need it again, maybe I'll go back on it. What do you think about that?
So let's start with the second part first. Please don't do that. And the reason why I say that is if you keep doing that over time, we know from weight regain studies that the majority of the weight that comes back is fat. So you lose muscle and fat, but you regain only fat. If you keep doing this over time, more of you is going to become fat and less of you is going to become muscle. These are not drugs you take for the short term for, hot guy, hot girl summer. Right? So, all right, so getting back to the first bit, so please don't do that, like I said. Now going back to the first bit, when you look at the adherence data with GLP-1s, depending on which study you look at, you range from about 37 to 80% of people are stopping within a year. The latest paper out of JAMA Open basically suggested about 50% of people quit these drugs within about a year. If you look at the risk factors as to why people quit these drugs, number one, it's because of the side effects. And the funny thing is, quite often, of course, there's nothing funny about side effects. What I'm saying, though, is that a lot of times when these drugs are prescribed to individuals, they're given without lifestyle support. Let me give you an example. We frequently at the university, when we're recruiting subjects for our clinical trials, we'll get patients from outside the university that enroll in our trials. And so we had this lady who was all set to get rid of, she enrolled for our GLP-1 study saying, but, I'm kind of thinking of going off it. We said, well, first of all, if you go off it, you're off the study, but what's the problem? And she said, well, I'm sorry you've all eaten, but she said, I have uncontrolled diarrhea on this drug. Okay, well, has anyone told you to take soluble fiber with it? Like Metamucil? No. Well, can you try that? 3 days later, she's like, that's all it took? And so the point I'm trying to make here is that these medicines should be given along with appropriate lifestyle support. You need to be able to talk to a registered dietitian. You might need to talk to an exercise physiologist and sort of manage those things. So, so that's problem number one, which is the side effects. Problem number two that causes lack of adherence is money. So if you look at the study that I'm referencing, once you make less than about $80,000 a year, your adherence drops, and that's because of the cost and the out-of-pocket costs that are associated with it. If you're older, you're less likely to stay compliant. So at the end of the day, when you think about these things, what you want to do is sort of try to build a risk profile for a lack of adherence and target those people early on and figure out a way in which you can get them to stay on. And I don't know if you're doing this right now, but one way in which you can also consider getting people to be more adherent is using a behavioral economics approach. So years ago, we published a paper with exercise and trying to get people to be adherent. And the way we did it was you got a daily exercise target. And when you hit that target, 10% of the time you got a text message. Trust me, no one cares about the text message saying congratulations. 10% of the time you got $5, and then 80% of the time you got $1. But then over 2 years, we essentially ended up meeting physical activity guidelines in this entire cohort of obese, non-active Americans. So, there are different approaches you can play with to see if you can get adherence up, but that's definitely going to be one of the things to tackle.
Yeah, and I think like in the eMed model, we have different employers choose what their incentive is or what their contribution is. But we've had some employers that you have a much reduced copay if you're adherent.
Yeah.
And you can still get the drug if you're not as adherent, if you're not checking in every week, but your copay is going to go up. So it's like the carrot and the stick. And I think that people realize the benefit of having that low copay for a GLP-1 or the low cost share is so much more beneficial than not checking in every week, that they do it. I mean, it's sad, but it's kind of sad, but it's kind of true. And also, I do think that it's also positive reinforcement. When you weigh yourself and you see that you're successful at something, instead of never losing weight and never having that positive feedback, you're all of a sudden getting this positive feedback in a community that supports you with lifestyle. I think that drives adherence, because a lot of the times we get a question, and Scott, maybe you can comment on this, but like a lot of when we go and meet with companies, say, how do you assure adherence, right? How do you know? So we don't come into somebody's home. We have them scan their pen. We have them scan their pill bottle. We have them stand on a scale. But we don't know if you're swallowing that Wegovy pill. And we don't know if you're taking that shot or giving it to somebody else. But then when we see their weight check-ins, we can see that they are adherent to the drug. And I think people like that.
Yeah, this is a really complex and even confusing issue, I think, much more so than is appreciated. Initially, it was assumed that adherence was poor with the GLP-1s because they were so expensive. But when you look at studies comparing adherence on obesity GLP-1s with adherence on diabetes GLP-1s for diabetes, there's not that big a difference. A little bit higher with obesity, but not that much. And typically, diabetes medications are well covered. And so, certainly there's plenty of cases, but on the whole, I don't think that cost is the overwhelming driver of cost to the patient is the overwhelming driver of adherence. Side effects were then put forth as the potential reason. But there's a problem there too. For one, sure, we see side effects sometimes with the GLP-1s, but we don't see it that much clinically, and the vast majority of side effects we see are fairly mild and fairly manageable, without that much difficulty in clinical care. When you look at adherence for patients to hypertension medications, which on the whole tend to be pretty well tolerated medications, kind of the same thing. There's not that much better adherence to hypertension medication than there is to GLP-1s. And that suggests that side effects are not necessarily such a strong driver of difficulty of patients staying on the medication. So I think there's a little bit of both of those, cost and side effects, but not that much. I think to your point that sort of the whole picture, having ongoing counseling and support in a non-judgmental way, having clinical strategies that help both to manage the side effects and help to predict and even preempt life getting in the way, which is often something, sort of why people fall off, not forgetting to pick up their prescriptions and, not having a hard time getting in touch with their doctor to get a new prescription for a refill, things like that. I think that those things ultimately, in aggregate, tend to go a long way. And I heard, I haven't seen your data, but I heard that eMed has 90% adherence rate.
Yes.
I mean, that's
Above,
unheard of. I'm sorry?
92.8.
Sorry, I didn't mean to shortchange you there.
Yeah.
I have to thank my data team for that.
That is an unbelievable number.
Yeah.
And so I look to see how that plays out further with more time.
And actually, our partner company in the UK, eMed, is going to have a paper published in Nature, probably next month or 2 months. And they have 75,000 women in the study, and they had 0 major gastrointestinal events. Like there's never been a study like that, 80,000, because they keep them on the lowest effective dose, not the highest effective dose. Because there really is no highest effective dose is what is. And that's a little difficult. And I think we could talk a little bit maybe about the FDA and the drug studies, because when you look at the package inserts, they recommend a much higher maintenance dose than what we see clinically. And maybe Scott and then Sid, you could talk about, because Scott is, he's practicing every day. What do you see? Because, a lot of, when we go on these meetings, and I told you, I went from a clinician to being on a sales team in a very short amount of time, so I'm learning very rapidly. And people, the business side, and employers ask, what is the maintenance dose? And I try to explain to them, a maintenance dose is personalized. It's not the same maintenance dose for everyone. Maybe you could talk a little bit about that.
Yeah, so this has been a big headache clinically for the past few years. So it's not uncommon, and it was extremely common, for insurance companies to push us to raise the doses, or they wouldn't continue to cover the medication. So if a patient was doing really well at a low starting dose, we just wanted to keep them there because there was no clinical reason to increase, they often would say, well, you have to increase it or we're not going to pay it anymore. And that probably came from the way that the medicine was initially studied and then approved. So Wegovy, which is the weight version of Ozempic, that was studied in the phase 3 clinical trials. It was studied where patients started at 0.25 milligrams for a month, and then they went up to 0.5 for a month, and then they went to 1 milligram for a month, and then 1.7 for a month, and then they were at the 2.4 maintenance dose. And it was a very positive trial, which ultimately led to FDA approval, and the FDA approved it in that way. The 0.25, 0.5, 1 milligram, and 1.7 milligram doses were stepping stone titration doses, and the 2.4 was considered the sole maintenance dose. And because of that, that likely led to the company policies to cover the medication in that way. And and then it was just like this automatic thing where patients had to keep dialing up the dose in order to continue to get coverage with the medication, if they were even lucky enough to get coverage for the medication. That's been a problem. At first, no matter what we do, we couldn't get the insurance companies to allow people to stay at lower doses. Then slowly we were able to get it a little bit, but not without just a ton of wrangling and time and prior authorizations, and then talking to the next level of prior authorization and so forth. We're starting to get to the place where they're more flexible in what they cover in terms of the different doses, and that's incredibly important because for one, lower doses, if they're effective, almost always are going to be better tolerated. Almost all the side effects are dose related. So sometimes we have to go up because we need better efficacy, but it's common that we can stay at low doses at least for a decent amount of time and therefore have better tolerability. But the other thing is the way that the weight regulating and appetite regulating systems in our bodies is that over time we tend to build tolerance to any of the medications that we have ever had for weight, including today. And that's not entirely different for bariatric surgery, which is a very good intervention, but over time, appetite is more challenging and weight tends to go up at least somewhat on average with bariatric surgery as well. And so the other benefit of staying at lower doses, if they're reasonably effective, is it gives us more runway. It gives us more opportunity to increase when needed over time. So it's been a developing process here.
Okay. Sid, I have a question for you about exercise. So I'm going to be a little bit of a snitch, but when I got to eMed, there's a lot of young women working at eMed, and they're amazing, and a lot of them on the GLP-1 program because they were very excited that it was available to them and it hadn't been available to them. And I'm a 54-year-old running to the gym across the street between my train ride home to try to work out, and none of them are going to the gym. And I got really upset, and now I have them all going to the gym. Can you talk about the difference of like aerobic and resistance training and how much that contributes? Because people will say, oh, you don't need to exercise to lose weight. And I think there's a lot of confusion about that. And can you talk about that?
Yeah, so Great question. Full disclosure, I'm a fellow of the American College of Sports Medicine, so I'm extremely pro-exercise. But, so first things first, like I said, we did a big study last year. It was published in BMJ, and basically 454,000 people, 13 years of follow-up. And we categorized people based on cardio, this is aerobic fitness, between being the least fit bottom 20th percentile, and we considered them unfit. And then the top 80% that were considered fit. So that's a really generous description of fitness. If you want to meet this as a 55-year-old, try this tonight at the hotel gym. Get onto a treadmill, crank it all the way up to 1.7 miles an hour at a 10% grade. And if you can last 3 minutes, congratulations, you got out of the bottom 20th percentile and you would be considered fit. But when you look at the risk of death, all-cause mortality, so death from all causes was 50% lower. In fact, the obese, fit individuals had half the risk of death as the skinny people that were unfit. All right, that's all-cause mortality. And when you look at cardiovascular disease mortality, it lowered your risk by about 50% as well. So enormous benefits there. Now, one of the important things about that, along with GLP-1s, is you want to maintain your cardiorespiratory fitness at the end of the day. And we published a paper on this last year about the GLP-1s and what happens to fitness. And what it showed was you do get skinny, but you don't get any fitter. So the old belief, which was you can be fit or fat, is not true. You can lose a whole lot of weight on GLP-1s, but if you're not exercising, you're not getting fitter. Now, let's pivot now to resistance exercise. This is important, and I want to talk to the women in the room here for a second, especially because you brought them up.
Yeah.
The average 21-year-old female has the quadriceps strength of your quads in your thighs. A 21-year-old female has the quadriceps strength of a 75-year-old male. All right? You live longer than we do. Cool. But you're more likely to require assistance as you get older. So please, God, lift weights. And in fact, when you look at the data, this was one of my colleagues, Carrie Moreau, out of CU Anschutz. In fact, females get a much bigger bang for their buck when they lift weights. It's not complicated. You're not going to look like men. You don't have testosterone. It's just not going to happen. You'll get a lot stronger, though. You just got to do it twice a week on non-consecutive days, and it's great. And the other thing, too, is with GLP-1s, with the concern with loss of fat-free mass, where you have half of fat-free mass is muscle, and you lose a fair bit of fat-free mass. So if you look at the GLP-1 loss, it's 25 to 39%. Age-related fat-free mass is loss of age-related fat-free mass is 8% per decade, so it's quite a bit. But if you lift weights, and in fact, a week ago I was chairing a session on GLP-1s at another conference, and one of my colleagues from Western Australia showed data on women that did resistance training, heavy weightlifting during GLP-1 therapy, and even though their fat-free mass was lost to some extent, they preserved half of it, and they still got stronger. So it's important that when you think about GLP-1s, of course we know that they improve life. It appears that they have the potential to improve lifespan. What you also need to remember is that exercise increases your health span. So don't forget about it.
You know, there's still so much misinformation and misconceptions and myths around the GLP-1s. And I think a lot of it was born out of that 2020, 2021 period when Ozempic became part of the zeitgeist. I remember the front cover of The Economist magazine. This was late 2020 or early 2021. Front cover of The Economist magazine. And this isn't Mad Magazine. This is a great scientific publication. The cover showed, if I remember, an Ozempic pen maybe going into a hamburger or something like that. And the title was The End of Diet and Exercise. Because we have these magic GLP-1s, nobody's going to have to exercise anymore. You don't have to pay attention to what you eat or whatever. And that was one of any number of really confusing and unfortunate media and social media declarations that happened around the time that I think still, to some extent, persist today. So, you know, I think it gets to something that you pointed out, where it's not enough to just cover these medications. It's not enough for people to just get these medications, but they continue to need support and guidance and myth busting and ongoing care, and that will likely, improve just the objective outcomes of the medications themselves. That likely improves things even further over time.
I'm going to go a little bit off topic but I want to ask you about mental health and GLP-1s. And I can tell you as a clinician, I saw crazy improvements, things that we weren't measuring at all. Patients would come in and say, Dr. Hes, I used to bite my cuticles. And all of a sudden I realized my cuticles are fine, but I didn't make a conscious effort to stop biting them or something. And the studies now that are being done on alcoholism and depression, and maybe if you could both comment on that.
Look, I think there's lots of different aspects of this. For one, there are some of the sort of softer outcomes in terms of mental health. Like this thing that has now become popular, food noise. That's a big deal for a lot of patients I see. The benefits of not having to think constantly about food and what to eat and what not to eat, and always having a part of your brain being active in that is often a better benefit, they say, than the weight loss itself. So I think that's a bit part of it. An interesting thing is the maker of a medication that was approved in 2014 for obesity called Contrave. This is a combination of an old antidepressant called bupropion and an old addiction medication called naltrexone. And you put them together, and they actually work pretty well for weight loss. Not as good as the GLP-1s, but still reasonably good. And because there's an antidepressant in it, there's this assumption that it's the best medication to use for people that have depression. So the company came to me and a psychiatrist we work with and a couple other folks and asked us to do some research so that they could popularize the use of that medication in people with obesity and depression. And we studied it alongside the other obesity medications as well. It turns out that the GLP-1s lead to better improvements in depression than this medication that has an antidepressant in it. And so I think that's it's a pretty good flag to wave for the use of the medications for mental health.
And the other thing that you might be seeing, when you look at things like quality of life, it's important to recognize that obesity in the U.S. is extraordinarily heavily stigmatized, particularly if you're a woman. If you're a few pounds overweight, there are serious social consequences to it. To be fat in the U.S. doesn't just mean that you're horizontally challenged. It means, people are going to think you're ugly, stupid, lazy, lack willpower, insert favorite pejorative term. So that's obviously bad from a societal perspective. And I suspect that those improvements you're seeing might have to do with the fact that suddenly now these people are no longer facing some of that stigmatization that is basically hard-boiled into our culture.
Although there's new stigmatization
around
GLP-1s.
GLP-1s,
They think
it's
the easy way out, which is insane.
God.
Imagine if we made fun of people for going on a hypertension medication to treat their blood pressure. But that's what sometimes happens when it comes to the GLP-1s. And that's also, yet again, I've said this 4 times, and you've said it a couple times, it's also why it's so important to have this wraparound care with the medications, in part to support patients and in part to counter a lot of the messages they're getting, including potentially from their healthcare providers.
It's unfortunate. If you ask Joe Sixpack on the street what causes obesity, they usually say it's a lack of willpower, but it's really a matter of biology. And to go to war against obesity, it's a war that only the intrepid take on, one in which only a few prevail until now.
Yeah, and that's why, when we started doing this, nobody else wanted to do it. I remember when I asked my chairman, can I study obesity? And he's like, go for it. Nobody else wants to do it, Dyan. And I literally had, when I was in residency, I had a doctor, when I was doing my research and started clinical research in obesity, I literally had a preceptor who said, I wouldn't touch those patients with a 10-foot pole. And you're in medicine. And he said it out loud. And you're like, are you joking?
And
they're
that
not.
hasn't entirely changed.
Right.
When we were texting yesterday, I looked back in our texting string from a couple of years ago, and I think it was 2022 or 2023. You texted me and you said, I have this son of a patient of mine. You were in New York at the time, and the son lives in DC and needs help with weight, and can you see them? And I told you, I'm happy to see them, but I have no expertise in treating kids. And unfortunately, there's nobody in DC that actually treats pediatric obesity explicitly. And that's also slowly changing, but not that quickly. It still is a very much underserved area.
Yep. So as we were walking in, Sid is master of facts. He's like a Jeopardy show. But we were talking about, and he was mentioning the military. And he does some consulting work for the DoD. And we have a lot of, at eMed, I know we have a lot of ex-military or military families, and about the coverage of GLP-1s. Why don't you tell them a little bit about it?
Yeah, sure. So for the last 7 years or so, I've been a consultant for the U.S. Air Force and the Department of Defense. And so they frequently give me problems to solve. But once a year, the Pentagon hosts a conference called the Threat Summit, which is usually held at Andrews Air Force Base. And last year, they asked me to brief them on GLP-1s. Why? Because the utilization of GLP-1s in the services has gone up 100-fold. And the concerns were largely centered around the loss of fat-free mass and muscle, and how do you make sure you maintain performance, human performance. And so, yeah, we had a long chat about that, but this is really an emergent area that we need some solutions for. There's some data to show that maybe exercise can help, obviously, like I said. There are some potential drugs that are in trials right now that might help preserve that loss of muscle. So, we have to approach this problem with some humility because it's early days, but I think it's going to be something we end up solving.
And what about the cost of the drugs for the military?
Oh, boy. Yeah, they're considerable. Yeah.
The increases. And do they cover it?
It is, yeah.
Okay.
TRICARE does, but at the same time, they have to jump through a number of hoops, and plus, if you're, say, a pilot, then there are other issues, right? Nobody even knows what drugs. I mean, when you're a fighter pilot or something like that, one of the issues you're going to run into is, are you allowed to take that when you're getting into the cockpit, right? And not a lot is known about these things, so still early days.
And then talking about the future of obesity care, because everybody who has social media hears about Retta, and these peptides. And we discussed this last night, and maybe you can share your opinions about this gray market for weight loss drugs and the dangers, and what you think about retatrutide that is going to come out, and if it's going to be available for everybody. I'll let you guys answer. I don't want to give my opinion. Yeah.
Please.
Yeah, so Retta, the data on Triumph-1 came out at the ADA conference that was going on over the weekend. And the weight loss results are something. It's 31% at about 31% body weight at 80 weeks. And unlike semaglutide and tirzepatide, which levels off with weight loss at about 52 weeks, Retta appears to level off at about 80 weeks. So they actually went out almost 2 years of follow-up. So the weight loss was considerable. The reduction in knee pain in people with osteoarthritis was about 70%, which is staggering. But at the highest dose, they also had the highest level of dropout because of side effects. So, of course, this is not a drug that's yet approved, and we still don't have any visibility right now into what happened to their body composition, like what is the nature of the weight that they lost. So we got to hold on for that until the full paper's out. So that's where we're at. So we'll see how that goes. But if that 30% number is real, a sleeve gastrectomy might be obsolete, which is a type of bariatric surgery procedure. Scott?
And Scott, maybe you can talk about patients who've come to you who've used non-FDA approved drugs versus the FDA approved drugs and things like in that.
Yeah, the world of weight loss and obesity medicine has always been a bit of a wild west. And It started to improve a little bit in the 2010s, in part with the creation of the American Board of Obesity Medicine and certifying doctors in treating obesity. And so it was getting a little bit better. And then with the whole Ozempic craze, things have in some ways really gone down. Again, there's a lot of myths. There's a lot of people doing some crazy things, getting peptides from who knows where. There's a lot of inappropriate use, even of otherwise appropriate medications, where people are using it to lose 5 pounds, to fit into a bikini or something like that. These are real pharmaceuticals. They have risks, and with all medications in all areas of medicine, appropriate risk-benefit stratification is essential. So, there's a lot of reason to be excited, but there's also some reason to be cautious in our field. Thinking back to when these medications started to get big a few years ago, I was concerned from the very beginning that we may be running into a situation where, when you amplify even very small risks by many-fold greater utilization, that we may end up seeing a lot higher rates of otherwise rare things come up. And thankfully, we haven't seen that. But used inappropriately, bad things can happen. So we need to be vigilant about that. Finally, the FDA looks like it's putting its foot down at least a little bit on these unapproved peptides and the ridiculous mass compounding. But we're still in a situation where it's very much a Wild West.
And then to wrap it up, if you both had to give advice to a CFO of a company who is looking to get a GLP-1 plan for their company, or getting rid of it, actually, which is what we're seeing a lot of, what would your advice be to them?
Want to go first?
Sid's like, not it.
I mean, if it was someone who's skeptical about these, I would show them the data on comorbidities of obesity, which is extensive. We published data a few years ago showing there's 236 conditions linked to obesity. Not all of which necessarily improve with treatment, but many of them do. I'd show them the data on improvement in comorbidities, especially the bigger ones, cardiovascular disease and osteoarthritis and chronic kidney disease. I'd show them the growing but still limited data on cost effectiveness. And I'd certainly point out the fact that Medicare, after 15 years of working on trying to get Medicare coverage, that Medicare, beginning in about 3 weeks from now, is going to cover GLP-1s for a range of Medicare beneficiaries. And so hopefully those sorts of things would be enough to convince a CFO. If it was a really precise CFO that really wants to see just absolute black and white, without question data on huge health improvements, immediately upon starting the medication, that's not something that we can prove just yet. But I think if you go to the CEO who might be thinking a bit more broadly and talk more about employee satisfaction and other potential benefits, presenteeism, absenteeism, quality of life, and just sort of feeling good among their employee group, I think that might be a little bit easier sell. And then if you talk about going to a CMO, chief medical officer, I think most chief medical officers would agree that not covering GLP-1s for appropriate patients, is almost borders on malpractice.
Yeah, agree with everything you said. The main thing I would add on to that primarily would be that, as Scott indicated, I think patience will also be key. And what I mean by that is, if you're looking at outcomes such as cardiovascular disease, just to use an example, cardiovascular disease starts in people in their first decade of life. It becomes symptomatic maybe in their 40s, 50s, or 60s. But the point I'm trying to make by giving you that depressing piece of news is that this is a condition that has probably been baking in a human for 4 decades, 5 decades. And then when you start them on the drug, it's going to take a while for that effect to start showing up in the data when it comes to prevention of cardiovascular events, hospitalizations, mortality. It's going to take time. It may not happen in a year or two, but it's likely going to happen. And so patience would be a virtue when you look to evaluate the effectiveness of these drugs on your human capital.
Great. Thank you. Thank you, everybody.
Cool. Thanks.